Two tiny bodies, no bigger than a hand, wrapped in tubes and light. One baby reaches out and an arm crosses the space between them. Her sister breathes again. In an instant, a simple touch rewrote how we think about caring for the most fragile among us. This is the rescue hug. Follow echoes of time. In the months before Kyrie and Brielle Jackson were born, their world was still only possible in hope. In 1995, in a Massachusetts hospital, two sisters arrived at 28 weeks gestation, each one a universe of possibility and vulnerability. They were so small that a wedding ring could have slid over a wrist. They were so fragile that every breath, every heartbeat, every tiny rise and fall mattered more than most of us can imagine. Kyrie was the stronger twin from the start. She was small, yes, but her color held, her numbers, though shaky, improved. Brielle, by contrast, hovered on the thin edge that neonatologists know all too well. Her chest worked harder than it should have. Her skin went dusky. Her heartbeat stuttered and surged. Machines told the story with cruel clarity. Nurses changed settings, repositioned tubing, exchanged measured words in whispers as if not to startle a fragile rhythm. Doctors considered medications, respiratory maneuvers, and every protocol they had learned in training. Yet Brielle's body seemed to be losing a private contest against immaturity. Then, someone in the room made a suggestion that felt small and brave. Put the twins together. It was not an experimental drug or a new ventilator. It was a human idea, an instinct born of observation, of the knowledge that infants find signals in touch and scent, in heartbeat and warmth. In some hospitals and cultures, skin-to-skin and co-bedding practices were already known. In this unit, the notion of placing two very premature infants in one incubator was unconventional, risky, and desperately hopeful. With careful planning and the consent of their parents, the team prepared the incubator for both babies. When Kyrie was moved into the same chamber, what happened next was quiet enough to miss if you blinked. Kyrie, almost without thinking, extended a tiny arm and draped it over her sister's shoulder, a gesture both instinctive and profound. It was a small act of alignment, an infant's attempt to share warmth and presence. The monitors registered the moment with numbers that would later be cited in papers, in training seminars, and in whispered retellings. Brielle's oxygenation improved, her breathing became less labored, her heart found a steadier rhythm. The color returned to her cheeks. The whole team paused as if the room had exhaled together. Cameras photographed the scene, and the image traveled. People named it the rescue hug. There is a tendency, when we look back at a single image, to want to turn it into a myth, to say the photograph caused a revolution, that one instant overturned decades of practice. The truth is both humbler and more powerful. The rescue hug did not invent skin-to-skin contact. It did not single-handedly invent kangaroo care. In fact, the roots of skin-to-skin care go back earlier, especially to innovators in resource-limited settings who recognized that a parent's chest could be a life-saving incubator. What the rescue hug did was make an idea visible. It put a face on a practice, and in doing so it helped clinicians and families see, in human terms, what data had been suggesting. Touch matters. To understand why touch matters, we need to step back into fetal life. In utero, a developing infant learns to regulate body temperature, heart rate, and even breathing patterns in the warm, rhythmic environment of the mother's body. Birth suddenly exposes a premature infant to an environment for which they are not yet fully prepared. The coolness of ambient air, the abruptness of noise, the unfamiliarity of separate bodies. Machines and medicines substitute for many of those functions, but they cannot replace the biological orchestra of warmth, the sound of a heartbeat, the scent of family. When a baby is held against a chest, skin receptors and tiny blood vessels respond. Body temperature stabilizes. Cortisol, the stress hormone, can fall. Breathing can coordinate. The nervous system, fragile and impressionable, receives a language it can understand. This physiological reality is why kangaroo care, the practice of skin-to-skin contact developed in parts of the world where incubators were scarce, became an evidence-based strategy. It was low-tech, yes, but deeply tuned to what biology needed. Over time, research has documented benefits. Improved thermal regulation, better breastfeeding rates, more stable heart rates, and sometimes shorter hospital stays. The rescue hug sits in that lineage. It is the moment when two babies, who had shared the same womb and the same gestational clock, found a way to continue that intimacy outside it. The photograph of Kyrie and Brielle became a kind of mirror. For parents who had been through the NICU, it reflected a truth they felt in their bones. Closeness heals. For clinicians, it became a conversation starter, a gentle prompt to ask, when safe, how to bring parents nearer, how to enable skin-to-skin sooner, how to consider co-bedding twins in units where careful monitoring made it feasible. For the public, the image distilled complexity into compassion. A tiny arm across a sister's shoulder, and the world sighed with relief. But the arc from a single rescue to broad changes in practice is neither instant nor linear. Hospitals differ in resources, in training, and in risk thresholds. A unit's priority must always be safety. For some infants, profoundly unstable, heavily ventilated, or with complex anomalies. Co-bedding or immediate skin-to-skin may be impossible. For others, when the team assesses that the baby is stable enough, skin-to-skin sessions and family presence are encouraged. Over the years, clinicians have developed detailed protocols: warm room temps, secure positioning, continuous monitoring, parent education, and slow, supervised transitions that respect both the baby's fragility and the parent's need to touch. The rescue hug did not replace those protocols. It humanized them. There is another important dimension: the cultural and emotional effect on families. Being in a NICU is a grief-laced endurance test for parents. Many feel disempowered, reduced to watchers behind glass. Skin-to-skin restores agency. It allows a parent or sibling to do something profoundly active, to regulate, to soothe, to help the baby practice the simplest acts of life. When Kyrie instinctively touched her sister, it was not only an infant's comfort, it was a permission slip to claim closeness in an environment otherwise dominated by machines. Nurses noticed how parents changed when they were invited into the bedside rituals. They stood straighter. They breathed differently. They left the hospital with a new competence, not only in technical skills but in the quiet art of being present. Over the weeks following that first embrace, the twins' story unfolded with the slow rhythms of healing. There were setbacks, of course. Prematurity is rarely a linear arc. There were days of alarms and repositioning, of cautious adjustments to feeds, and nights where progress felt like inches rather than miles. Yet the trend moved toward home. Kyrie and Brielle gained weight, their respiratory needs decreased, and the day came when they were cleared to go outside into the ordinary noise of a world that had once seemed impossibly large. The family left with car seats and a bundle of fragile instructions, but they also left with a new vocabulary of touch, and a story that the community would carry for decades. The rescue hug has been retold in nursing classes, in parenting groups, and in policy discussions about family-centered care. Clinics that once limited parental presence extended visiting hours. Education materials began to emphasize kangaroo care as a complement to medical treatment. Research followed. Careful studies comparing outcomes for infants with early skin-to-skin contact and those without, meta-analyses that suggested modest but meaningful improvements in stability and bonding. These data helped move the practice from anecdote to recommended therapy in many settings, always with the caveat that clinical judgment rules. Each baby must be evaluated on individual grounds. Beyond the clinical lesson, the rescue hug teaches a moral one. It reminds us that the smallest acts can have outsized effects. It honors the courage of the nurses who suggested a reunification, the calm competence of the staff who performed it safely, and the instinctual wisdom of infants who still carry traces of their first home inside them. It also asks questions about access and equity. Not every family has the same chance to be at the bedside hour after hour. Not every NICU has the staffing or the layout to support early skin-to-skin care. The story of Kyrie and Brielle invites advocacy. For resources, for staff training, and for policies that prioritize family presence as part of medical care. When we look at the photograph today, the tiny arm over a shoulder, the quiet stabilization of vitals on a nearby monitor, we are seeing a nexus of science and tenderness. We are seeing an idea given life through human hands. The image does not replace rigorous trials, but it supplements them with a reminder that medicine is at its best when it joins technology with touch. There is also a quiet, personal afterstory. The twins grew. They marked birthdays, learned to crawl and later walk, and became members of a family that would tell their rescue hug story in living rooms, at reunions, and to anyone who needed to hear it. The parents who once learned NICU jargon by heart became advocates for other families, sharing what they had learned about holding, about asking, about insisting, gently and persistently, on being part of their baby's care. And so the rescue hug continues to matter, not because it was a perfect solution, but because it was a proof that closeness can be a therapeutic tool, that humility among clinicians can open a door to innovation, and that the simplest human acts often carry the deepest medicine. In the quiet of a night shift, when a nurse's hand rests on a parent's shoulder as they practice kangaroo care, the echo of that tiny arm across a sister's back lives on. If you work in a NICU, if you have loved someone who was born early, or if you simply believe that small acts can change lives, then this story is for you. Let it remind us to look for humane solutions, to listen to the instincts of parents and caregivers, and to balance caution with courage. Thank you for spending this time with Echoes of Time. If this story moved you, follow the channel for more true histories of quiet courage. Share the rescue hug with someone who needs to feel hope today. Until our next echo, take care of yourselves and each other. This documentary describes one clinical event and general research about skin-to-skin contact. It is educational in purpose. Clinical decisions are medical and situational. Always consult licensed clinicians for specific care choices.